In November 2016, the RCPCH, the Royal College of Paediatrics and Child Health, produced a service review report into the Countess of Chester's neonatal services. To place it in context, this was 4 months after the neonatal unit had been downgraded from a Level 2 local neonatal unit to a Level 1 special care unit. Today I'm going to read from that report, starting with the introduction and then moving to Section 4. Section 1. Introduction 1.1. The RCPCH was approached in June 2016 by Mr. Ian Harvey, Medical Director, to conduct an invited review of the neonatal service at the Countess of Chester Hospital NHS Foundation Trust, COCH. The review team comprised 2 paediatricians with special interest in neonatology, plus a senior neonatal nurse manager and a lay reviewer. The Trust provided a range of documents for review, and interviews with relevant staff and others as listed at Appendix 2 took place on the 1st and 2nd of September 2016 at the Trust. There were some additional conversations by telephone following the visit, and additional documentation received. A summary feedback meeting was held with the Chief Executive, Medical Director and Nursing Director at the end of the visit, at which the review team set out some immediate actions, which were followed up by letter the next working day. These and further recommendations are included in Section 5, 1.2. This report provides an independent critique of the service against agreed terms of reference, taking into account published policy, guidance, and standards developed by the RCPCH, other professional bodies, and the Department of Health, together with the objective operational experience of the review team drawing on and supported by the resources of the RCPCH. It is the property of the Countess of Chester Hospital through the Medical Director, and remains confidential between the Trust and those appointed by the RCPCH to produce the report. However, the RCPCH encourages wider dissemination of this report by the Trust amongst those involved in and working with the service. 1.3. The review team would like to thank all participants for their hospitality and engagement with the process, their openness and their time. We are now going to scroll forward to Section 4, which begins with a previously redacted passage concerning the consultant's allegations against Lucy Letby. 4. Findings. The individual nurse. On arriving for the visit, the RCPCH review team was told that Nurse L had been moved to an alternative position around 10 weeks previously, without explanation nor any formal investigative process having been established. The review team was told that the individual was an enthusiastic, capable and committed nurse who had worked on the unit for 4 years. She herself explained to the review team that she was passionate about her career and keen to progress. She regularly volunteered to work extra shifts when available, or change her shifts when asked to do so, and was happy to work with her friends on the unit. The directors understood there was nothing about her background that was suspicious. Her nursing colleagues on the unit were reported to think highly of her and how she responded to emergencies and other difficult situations, especially when the transport team were involved. There were apparently no issues of competency or training. She was very professional and asked relevant questions, demonstrating an enthusiasm to learn along with a high level of professionalism. When the neonatal lead made allegations to management, the director of nursing considered supervised practice for the nurse L, but the consultants would not accept this and required the nurse be removed from the unit. Senior operational staff on the unit reported being very upset at the situation, and the neonatal nurse manager in particular explained the difficulty of wanting to support Nurse L and managing morale and anxiety amongst the other nursing staff who were not aware of the allegation. The consultants explained that their allegation was based on Nurse L being on shift on each occasion an infant died, although not necessarily caring for the infant, combined with gut feeling. There was no other evidence or history to link Nurse L to the deaths, and her colleagues had expressed no concerns about her practice. The decision was taken to redesignate the unit to a special care unit from the 7th of July. Nurse L was on leave for 2 weeks from the 30th of June. On her return, she was told that she would be supervised for a period, and that others were also being supervised. She was not told of the specific allegation, but she was made aware that there were concerns that she was on duty for each of the deaths. At a subsequent meeting accompanied by her union representative, she was advised that supervision was not possible, due apparently to staffing levels, and she would be temporarily redeployed. She was apparently advised again that this would also happen to other members of staff. She was told not to make contact with staff on the unit. Nurse L had incorrectly been told that the RCPCH had suggested that she be redeployed and that the review would resolve the issue within 2 weeks of the visit. No formal HR process had been put in place for the 10 weeks between the redeployment and the RCPCH visit. The RCN support to the nurse had, up to the RCPCH visit, not been very active, but it was expected that the nurse would raise a grievance. In the light of information shared with the review team, the RCPCH advised the Trust to follow corporate processes in responding to allegations of misconduct by opening an investigation. It was also recommended that a full and detailed independent case note review was required on the deaths, prioritizing those that were unexpected. Recommendation: conduct a thorough external, independent review of each neonatal death between January 2015 and July 2016 to determine any factors which could have changed the outcomes. Include obstetric and pathology / post-mortem indicators, nursing care and pharmacy input. Recommendation: ensure there are clear, swift and equitable trust processes for investigating allegations or concerns which are followed by everyone. 4.1. Is the service provision compliant with current professional standards? No. The team has self-assessed against service standards for a local neonatal unit and is non-compliant on nurse and medical staffing levels, environment and accommodation for parents, support from the community neonatal team and postnatal follow-up. 4.1.1. Neonatal care in the UK benefits from a range of clear and consistent service standards developed by the British Association of Perinatal Medicine, the BAPM, and adopted by government through NICE quality standards, the Neonatal Toolkit, and NHS England's specialised commissioning specifications for neonatal care and neonatal transport. These standards, guidelines and specifications set out expectations for staffing, numbers and experience, activity, transfer arrangements, environment, governance and patient-parent-carer experience. 4.1.2. The designation as an LNU, a Level 2 local neonatal unit, requires medical cover as follows: at least 7 on-call consultants, including at least 1 neonatal specialist. Compliant: a Tier 2 rota shared with Paediatrics with at least 8 staff. Not compliant: a Tier 1 rota separate from Paediatrics with at least 8 staff. Not compliant: units with a high proportion of intensive care should have enhanced staffing. 4.1.3. The consultants appeared confident about carrying out neonatal care, but they are concerned that they would lose skills if the status of the unit remains at SCU, Level 1 Special Care Unit. They are able to actively cool infants for transfer, reaching the target 6 hours, and the unit is performing well against peers for the standards measured through the NNAP program. 4.1.4. Nurse staffing levels are consensus-based and calculated as follows: 1 nurse to 1 infant on intensive care, 1 nurse to 2 infants on high dependency care, 1 nurse to 4 infants on special care. All nurses should have undertaken NLS, newborn life support. Compliance is monitored on a network basis through the BadgerNet returns. Across the network, nurse staffing is 27% below target. At the Countess of Chester Hospital, it is 21% according to a recent network audit. 4.1.5. The Paediatrics team has self-assessed against the 2015 Facing the Future Standards for Acute Paediatric Care, and stated compliance with all standards except the first. Consultant presence at times of peak activity. There are ward rounds at 5 p.m. weekdays and weekend mornings, contributing to compliance with the 14-hour consult review standard. There has been a hot week system since 2008-9, but a single consultant is insufficient to safely cover both the pediatric and neonatal wards. The business case for additional consultants will address this. 4.1.6. In terms of environment, the unit is well located, being adjacent to the pediatric ward and maternity unit, but its design reflects its age. The rooms are small, with cots placed too close together, making nursing more of a challenge, and lighting is inadequate. There is insufficient storage space, resulting in many pieces of equipment being stored in corridors. Direct visibility from one area to another is poor, and infants are moved regularly to accommodate acuity, an extra risk in the system. There is a £3 million fundraising appeal towards rebuilding the unit adjacent to the current facilities. A light, bright parent suite was opened recently with support from the Chester Childbirth Trust. 4.2. Are staffing numbers and competencies appropriate for the acuity of the infants cared for? No. The paediatric service, including neonates, struggles to fill its Tier 2 posts, and medical staffing numbers are inadequate for Tier 2 local neonatal unit, although sufficient for a Level 1 special care unit. The reported quality of teaching and training for doctors is, however, good across the paediatric service. 4.2.1. Although the unit is, on paper, compliant at consultant level, the high level of activity of the paediatric service means there are only 2 scheduled consultant ward rounds per week on the neonatal unit, yet 5 on the paediatric wards. This would not meet training requirements or RCPCH and BAPM guidance for a local neonatal unit. The appointment of 2 further consultants in 2017 is an extremely positive and forward-thinking decision, which will enable a dedicated consultant of the week for the neonatal unit. These appointments should be in place before the network and unit consider returning to Level 2 status. Recommendation: the 2 additional consultant appointments must be in place before any consideration can be given to possible redesignation as a Level 2 local neonatal unit. 4.2.2. The investigation reports from the infant deaths showed a pattern of insufficient senior cover and a reluctance to seek advice. The consultants reported visiting every day and being available on site 9 a.m. to 5 p.m., perhaps by supervising work on the postnatal ward and teaching. Given the acuity of the unit, pre-7th of July, there should have been a greater level of consultant presence on the ward. Recommendation: strengthen procedures for involvement of more senior advice, and develop guidelines for consultant availability to the neonatal unit. 4.2.10. Nurse staffing levels are frequently less than the recommended levels. There was a 21% shortfall in 2014-15. There are always 2 Band 6 and 2 Band 5 nurses on shift, but these are often covered by long-term agency staff. The CQC indicated that neonatal nurse staffing was of concern, requiring the Trust to ensure staffing levels are maintained in accordance with national professional standards on the neonatal unit and paediatric ward. 4.2.11. In terms of acuity, network data available to the team had indicated that the Countess of Chester Hospital has a significantly higher proportion of late gestation admissions, over 37 weeks, than other local units, 10.73% compared with 5.69% average for the 22 units, and this had been raised for several years. The 2015-16 data available in October showed the figure had fallen to 7.8%, lower than 2 other units in the region. A number of possible reasons for the higher level had been suggested, including the transitional care arrangements, differences in obstetric approach, reluctance to discharge, low thresholds to transfer in, or inexperienced medical staff. but the increasing trend towards the network norm was commendable, and monitoring should continue. That ends the reading for today. Thank you for listening. If you have enjoyed this video, please don't forget to like and subscribe.